Our next talk in this session is single center experience of Centrimag as ECMO in COVID-19. And I'd like to call Dr. Arpan Chakravarthy, Senior Consultant at Medica Super Speciality Hospital, Kolkata. Dr. Arpan.
Hi, hello everybody. Thank you for giving me the opportunity. Thank you, Morley. Whenever I go and speak about ECMO, I'm just a spokesperson because you all know ECMO is a team game. At least 20 people are just behind me who are invisible now, and I'm just their spokesperson. So it is a talk from our team, and I'm just delivering the lecture. This is our team. Obviously, it starts from us, the doctors, the nurses, the physician assistants, to the perfusionists, to the nurses, and all the technicians who are counseling for money to the relatives. They are also should be included in your team, because we have experiences of how they counsel and with the relatives and how the outcome goes on. That is also important, which we have found very important during this pandemic. And we know I'm from Medica Hospital, which we have started this program in 2014, way before Madam Jayalalitha's incident in 2016. And it picked up, this awareness about ECMO picked up after that. And we are available in our ECMO Availability Center map in this ELSO website, and our center number is 738. This is a newspaper cutting which came out in the first pandemic, in the just middle of this August, and which was very distressful to us, to our ECMO community, that 43% of our COVID-19 death is in between the age of 30 to 59. So that means the people who have died of lack of oxygen. So we could not reach, the ECMO could not reach the masses when it is maximum required. People argued that ECMO is a resource intensive thing. It should not be used in pandemic. People are dying of oxygens. But the contrary to the belief, it came out to be that ECMO should ideally be massively used in this kind of pandemic, this kind of respiratory pandemic, where the outcome of ventilation is not going to give you a good result. So we are, as an ECMO community from the ECMO Society of India, we are the believer of this ECMO awareness during this pandemic, and we have started doing a lot of webinars and awareness campaigning to get this thing up in the number. And obviously, what is the thing? The people asked me, who are you? Who are you? I told, I am the ECMO specialist. No, I know that, but what is your job profile? No, I am the best ECMO specialist in the world. He could not be convinced. Then I can convince giving this thing, because this guy, I have seen him, he has given food delivery in the first part of the pandemic, very smiling face. So I consider myself as a oxygen delivery boy when the lungs is not working. As an ECMO, what we do, we just give the oxygen when my lungs is not working, and the customers like heart, like brain, like liver, like kidney, they are receiving the thing. We have to follow this word only, and then you get where from this ECMO is going to help at that point of time. And this is a thing with thanks for the Centrimag, because there is a lot of machines. We had only 2 machines before that pandemic. We want to buy a lot of things. At least all the centers want to buy a lot of machines, but at that point of time, there is no machines available. Thanks to Centrimag, I don't know where it has been tagged as a VA ECMO or as a LVAD device that came into play as a ECMO device, as a VV ECMO device, and we bought a lot. And most probably different centers also bought this as an rescue machines for this, and we could perform at least 153 ECMO in both of the pandemics, and results were not very much okay. In the second part of the pandemic, we lost most of the people before, due to different reasons, but at least 51 people went home from us, and still 2 patients on mechanical ventilations after coming out of ECMO, and 6 still on ECMO now. And obviously, this femorojugular and femoral, mostly we prefer the femorojugular, but for the transport processes, from that retrieval things, sometimes we preferred femoral, because a lot of cannulas, neck cannulas were there in the different hospitals, so we didn't disturb it and put femoral and retrieve the patient from the different cities. So that's why the femorofemoral number is a bit higher in our hospital. So this number which is, I have calculated 130 cases where this mean PF ratio we have found 0.65. Proning, 75% people receive proning before ECMO, renal replacement therapy almost 30%. Myocarditis, which was not found in the latter part of the pandemic in our series, but first part of the pandemic, so came down almost 12%, shock liver almost 22%, cerebral issues like COVID encephalopathy, which came later on, latter part of this COVID run, circuit thrombosis, yes, which has been very much glorified in the first part of the pandemic. All circuits are getting clogged, and it has not, the story is not like that. We have seen only 5 cases of circuit thrombosis and cytokine storm, obviously. It's a good number of cause of mortality in our patients, almost 25% things. And obviously with Centrimag, you can transport these patients even on air, on an ambulance, which is very handy. 2-3 things which we are not comfortable with this pandemic ECMO run. That is, one is the cytokine storm, where we could barely cross those events. In 20 odd patients, we could use, even with the Centrimag, this console and all this, we could use cytokine removal by the cytosorb, but results are not optimal. We have used almost in 20 patients where only 4 people went home. One patient I have used 5 cytokine removal cytosorb continuously, and he went home, but result is not that great. Only 4 people went home out of that 20 where we have used cytosorb. And this was the use, we have make it as a serial filter. Dr. Soumitra was telling about the obesity. Yes, we could found a lot of obese patients in our ITU. This is 2 patients. I have to show, one is 150 kg and 160 kg. One of them was a doctor, and both of them went home fortunately with this good flow and this lung rest, and they went home. They did well with us, and he came with this is 9% oxygen saturation. So hypoxia, that can be that so much I want to see with this slide, and people should not die of lack of oxygen at that point of time. And obviously one thing is important, proning. Proning helped us a lot even on ECMO, early ECMO, prone the patient, proning, bronchoscopy, and early tracheostomy. These 3 has given us a good outcome with the people going home. So proning with this small circuits and these small machines, you can do it jolly well in your ECMO runs. Prolonged ECMO. Earlier we are talking about this in the tea break, that what was a normal ECMO run? It was 14 days. Then this H1N1 came, it was 21 days. We speak how we when we counsel the relatives how much ECMO run is required. Okay, 2 to 3 weeks. But now we are telling about 2 months. So prolonged ECMO runs has become a hallmark in our series now in our ARDS patients. And if you see, the air leak syndromes are much more prone to these prolonged ECMO runs. If you have a pneumothorax, you have a surgical emphysema, or you have a pneumomediastinum. And last part of the ECMO run, I think everybody will agree with me, last part of the ECMO run is always that kind of ECOR mode. They learn the deal with oxygen first, then they learn how to deal with the carbon dioxide. So ECOR mode running was probably 1/3 of a run in a prolonged ECMO. Somehow very low heparin requirement in such long ECMO runs. Sometimes we ran it without any heparin because of the low platelet. We could not give platelets, so we stopped heparin and we ran heparin free ECMO for this. And this is the bilateral chest drain ECMO. So these are the hallmarks of this thing. And we could mobilize this, but she was a doctor, dentist, got decannulated at day 48, and we could mobilize her on chair and on a regular basis after getting this acute ARDS thing over, and with this Centrimag system, which is very useful at that point of time. And obviously the patients can be put on chair and you go for a regular physiotherapy. You can see in these pictures. And if you see, he was one of our colleagues, he's a doctor, just before that vaccination started, he got affected, and he was put on ECMO. And we mobilized him, and he was a bit confusing state of mind, had some kind of encephalopathy at that point of time. But he came out, and that is the beauty part of this ECMO, that even if we fail ill, our fraternity fail ill, we can go full on with this and try to save them, this kind of ECMO warriors. And after this, he sent me this picture from home. He's moving without any problem, and he was a golfer, and he sent me this, but I'm fit as before the ECMO thing. So this is our story, success story. Obviously the failure stories are there, but this gives us good boost. We don't leave those patients when they go home. We follow them up, because most of the patients are still on oxygen support, still on their physiotherapy. So always follow them up till they become your Facebook friends. And 3 things, regular post-ECMO follow-up clinic we do with thromboprophylaxis, assessment of the residual lung functions, and the psychological boosting till they come back to your professional things. They become a true friend and true referral for your next patients. He is Somnath. He was our one of the longest long ECMO run patient. He has sent this thing to us, and he got very good from this cardiopulmonary exercise thing. And he sent me this picture to boost other patients. I show these things to my patients when they are getting awake and all this. He's doing things like this. She got discharged on day 81 of ECMO, post-pregnancy. She lost her baby, but got an ARDS, and we rescued her. Till day 81, she was there on ECMO, and obviously she came out of this. And he was on day 105 of VA ECMO because of the concomitant right ventricular dysfunctions. We listed him for heart-lung transplant, but inavailability of organ, and later on he succumbed to sepsis, and he died at the day 124 of the ECMO run. And he was the patient who actually post-COVID patient had CMV, first the CMV pneumonia, then followed by CMV myocarditis. We have to rescue him on VV ECMO, then his lung function, this heart function went down, and we put him on VAV ECMO. He was 10 days of VAV ECMO, his heart improved, and they continued on VV ECMO and got discharged after 90 days of ECMO. So these are the things, these kind of patients got benefited with this novel therapy of combined ECMO. And this is our ECMO ICU. At such a point in the second wave, we have ran 30 ECMOs at a time, and almost all, because most of the machines are bought in the form of Centrimag, it became a Centrimag ICU rather than an ECMO ICU. So at least we could save few people and could save those patients who are acute, who didn't die because of lack of oxygen. So that is our motto, and from the ECMO Society we also promote this as an ECMO awareness. The ECMO term should be used and it should be practiced from Kashmir to Kanyakumari. Thank you. And we believe in right to oxygen. She's one of our survivors' daughters. Thanked me. Thank you.